Welcome to The Treatment Plan, a podcast about how healthcare really works, from weight loss and patient care to the systems and incentives behind it all. Hosted by Jack Usher and David Usher, MD.
So this is episode 1, and of course this is we're talking about healthcare and policy, and nobody wants to really start with politics, but given the situation that we found ourselves in, we've got to start with politics just a little bit. But we're going to get more into the policy than anything here, because we're talking about H.R. 1, the big beautiful bill that recently passed the House of Representatives. Right. For people, I'm sure everybody's heard about it in the news, but it passed by a 1-vote margin in the House of Representatives, so it's not law yet.
We're waiting on the Senate to take it up and hopefully not carve it up so badly that nothing passes and we get delays.
Hopefully not. But the one fun thing I did notice about this bill is that the actual name of the bill, so people know the Trumpian reference to it, which is the big beautiful bill. But if you log in on congress.gov, the name of the bill is quite literally Big Beautiful Bill. So it will go down in history alongside the Civil Rights Act and the Affordable Care Act and the Big Beautiful Bill.
Oh, yeah.
So let's get into the details of this, because I think for all of the divisive and hotly contested political issues within the bill, what we're actually more interested in is a couple of sections that get literally no coverage in the press, but is actually a huge boon to what you do in the direct primary care space, on-site clinics, alternatives to the mess of health insurance right now. And I think more people need to know about what is shifting. The ground is really shifting beneath the feet of people in healthcare. So what actually happened in this bill? Well, there's 3 big shifts, actually. There's direct primary care access through HSAs. There's HSA expansion and flexibility, and there's a little bit of a shift in insurance design via choice arrangements. So we can talk about any of those or all of those, but we can go right on to the meat of it really is the direct primary care on-site clinic changes.
Right. Yeah. The background to that basically is that through the tax code and the creation of high deductible health plans with health savings accounts in the past, HSAs, of course, if you take money out of your paycheck, pre-tax, put it into an HSA, that's a deal the federal government is making with you, basically, that you will take this money and use it for purchasing healthcare, right? So in the old days, what that meant was with a high deductible health plan, basically until you spent effectively up to your out-of-pocket maximum or spent up to your deductible being what you pay before your insurance kicks in. Same thing for car accident, for example. You might have a $500 deductible before your car insurance starts paying for your fender bender. You have to pay the first $500. Well, in healthcare, it's the same thing. You pay the first X number of dollars, and under these high deductible health plans with HSA arrangements, that means you're on the hook for whatever that high deductible amount is. And the government said, we're going to create this pairing of HSAs and high deductible health plans. And high deductible has been defined by the federal government. So if you're going to qualify to actually save tax dollars by putting money in an HSA, you have to have a qualifying high deductible health plan, whether that's through your employer or if it's what you buy yourself. So that means you're more and more out of pocket every year. Those deductibles go up slightly. So what is a high deductible plan, or what was a high deductible plan originally? Maybe it was $1,500, and now a high deductible plan might be as high as $7,500 or $8,000, which is a crazy amount of money. So you can stick money into your health savings account, and the idea is that by doing this, when you go to pay a doctor's bill or a hospital bill, that HSA money is tax advantaged, right? And you're not taxed on it. And so it's above the line income, I guess they call it. And so people could spend that money for their bills and so forth, and they wouldn't have to pay taxes on it, which was, the idea of it was kind of good,
Mm-hmm.
However, what has changed and where the issue has been for those of us in the kind of call it the direct pay world or the direct primary care world, the rules set down by the federal government, primarily, I think, in the IRS rules, has been to say that people can't take money out of their HSA to pay for a direct primary care membership because that was just not how the IRS had it set up, right? And they couldn't see that far ahead. The tax code and laws tend to run far behind the marketplace. And so here we are. For years, we've been struggling with this battle of, patients can take money out and buy their health care, but you can't buy it in the form of a membership. You can only buy it on a fee-for-service basis. So since it wasn't laid down clearly in the federal law, that's been the challenge of direct primary care doctors across the country is, my patient has all this money sitting in that HSA and they can't pay for a membership with it. So then they don't join as members, and they wind up staying in the legacy health systems, paying on a fee-for-service basis, and they're subject to all the, let's call it, perverse incentives that go on in the major health systems. So for this to come along and say, we're going to do something different with that should get the attention of direct primary care doctors and employers everywhere.
Yeah, so just to identify exactly what we're talking about, I pulled this off of the House Ways and Means Committee website, where they publish, instead of looking at the entire bill and the actual legislation, which is really tedious to read and it doesn't actually tell you what happens, the committees publish, which I would encourage anyone to go read if you're really curious. They actually publish in common English what they're changing. They say what the current law is and then what is being changed. So what we're talking about here is the treatment of direct primary care service arrangements. Under current law, the IRS has indicated it views certain direct primary care arrangements as a separate and additional form of health insurance coverage, which means it's incompatible with HSAs, which can only be offered alongside an HDHP. That's a high deductible health plan. So the new provision says that it allows individuals with high deductible health plans to also enroll in direct primary care arrangements and maintain their HSA, and allows HSA funds to be used to pay for direct primary care services. And those distributions from the HSA for direct primary care services can't exceed $150 per month for individuals or $300 per month for family arrangements, and that's adjusted annually for inflation. So this really feels kind of like a huge deal.
It's a tectonic shift. It is. It's been the bane of we call them DPC, of the DPC doctor, the doctor who wants to operate outside of big system and provide really great care. We can talk about the value of DPC separately, but bottom line is DPC is a movement whose time has been coming even before this legislation, and now this legislation, I think, is going to really create an inflection point upward in the number of primary care doctors and even nurse practitioners and PAs and places, depending on how independently they can practice. There's going to be this big upswing in people who say, finally, we can practice medicine the way we want to, which is not to have to bill for every tiny little thing and then lose 40% of our billings to the process of getting paid, right? And therefore, this is a big shift. And it's long overdue, in my opinion, for better or for worse. But finally, here it is. Somebody's got to look at it, and hopefully the Senate won't screw it up.
No promises.
Right. But you never know. But we have good advocates in the Senate. I hope it doesn't get screwed up from the Senate. I would think this would be small potatoes for them, and they wouldn't even look at this, frankly. Hopefully they would see this as sensible and leave it alone.
In my very limited Hill experience, the stuff that gets battled out and reconciled once two versions pass, I mean, it's the big stuff that everybody, the changes to Medicaid and the tax cuts, and I mean, the really big stuff is what everybody has issue with. This feels like a bipartisan thing. I don't think there's any real politicking around this issue, which is good. That means it's if it made it into the bill, that's really the win.
At least they're talking about it for the first time. I think this is the first time it's ever been in a piece of legislation. I might be wrong with that, but first time it's ever been in a piece of legislation I thought had a chance of passing. Let's put it that way.
Yes. And that's another little tidbit for any listeners who might be curious. That is why these huge bills, unfortunately, it's where the process, it's how it works, but these huge bills are typically where a lot of things get changed. And that's why there's a lot of things that seem irrelevant or like a separate topic from whatever's being discussed. That's why there's so much interest and energy around these huge bills, because that's when everybody gets the chance to get whatever they want in the bill into a bill that will actually get passed. That they don't actually have to, they don't have to waste extra energy going through the entire legislative process for just their one thing. They just get it in a line item in a much bigger bill that is actually going to pass. So that's why this is so exciting. But the way I actually read this is just a different riff on what you were saying. Is it feels like with the change to allow HSAs to pay for this, it's like a recognition that this is not some sort of luxury good. It almost feels like it was in the same category as like a gym membership or like a wellness coach or massages, kind of one of these things. And for people who aren't in the industry or don't know anything about it, they would probably think the same thing. It's kind of a niche term. You're paying per month. That doesn't really make sense. It sounds like a gym membership, but introducing the HSA as a way to pay for it, it just opens the whole thing and it actually connects it in law or in policy to healthcare, which is exactly what it is.
Yeah, it makes it accessible to everybody. Really, there's historically there have been for decades these medical practices called concierge medicine, and if you aren't familiar with what that is, basically it's a doctor who opens a practice, and their practice model is to take on a group of patients in a membership format, and the patient chooses to pay it because that's what they want. And again, the benefits of that we talk about in a second. But the doctor would limit the size of his practice. Say, I'm going to take 400 patients, and then those 400 patients, or 500, or whatever that number is, depends on how the doctor does it, would pay a membership fee, and that membership fee could be $100, or it could be $500, or $1,000 a month. You wouldn't believe what I've heard. I've heard numbers way bigger than that even. And then when the doctor saw you, he would also bill your insurance for whatever it is that you did, so that he would get some additional payment from that. But you would also, things like labs or anything else he might provide for you would be paid for through your insurance, et cetera. So this was concierge medicine was always kind of considered for rich people, wealthy people, executives, people who could afford that membership, and so on. But it still involved having to figure out how to get paid through insurance companies or Medicare or whoever it was that you were working with. And the membership fees were just completely unrecognized, really, by the health insurance industry, by Medicare, Medicaid, everybody else. They were like non-billable services or non-covered services. You call it a scheduling fee, or you call it something that there's no insurance code for that, like a 99427 or something. There's just no code for that. It's a completely like a non-medical thing. So insurance wouldn't pay for it if the patient got a bill for it's called a concierge medicine fee membership. The patient just knew that's what they're going to do, and they were going to pay $200 a month, and that was how the thing worked, right? So that's been around for a very long time. And by the way, for your $200 membership fee, because the doctor limits his practice size, that creates a lot more access for each patient. So a patient can call all they want, and the doctor gives them their cell phone number, and they talk to them after hours or whatever. And that's just kind of the deal: is the doctor on call, and people can call or not call. If they're on vacation in Tahiti, they can call the doctor, and the doc would help them in the best way that he could. The trade-off for the membership is access, and it just feels different. Like you could call the doctor, and he would get on the phone with you perhaps and say, "Oh, hey Jim, how's it going?" and have a conversation. No appointment needed. The doc was happy because he already got paid the membership fee, right? I mean, he's been paid differently, so he can treat you differently. In the fee-for-service world, basically, let's call this Medicare or Medicaid for the most part, generally, or any third-party insurance. It's kind of a widget making process, particularly for family doctors, pediatricians, internal medicine. You got to get people through the door so you can create a billable service and send that off to the insurance company. And until COVID, nobody wanted to even pay much for telemedicine visits. So if I got on and Zoomed with somebody, that I couldn't often create any kind of documentation or anything that I could send to the insurance. They'd say, no, we don't recognize that as actual medical care. So you couldn't really offer that because you couldn't spend your day doing Zoom calls and not get paid anything, because how would you pay your staff or anybody to do anything, including yourself? So along comes this whole direct primary care thing, which is basically concierge care for the masses, if you want to think of it that way, right? Without the insurance billing. So there's a huge percentage of cost in healthcare. I've seen the number as high as 40%. I think it's lower than that now, but a big percentage of what the cost of healthcare is just the administrative side of billing insurance companies, right? And they say, "Oh no, we're not paying you for that," and then you have to resubmit a claim, do a little, jiggering around and go, "Oh yeah, that was a mistake," and resubmit a code, and you'd have to have staff people or pay a company to do all this stuff for
Oh,
you.
believe me, I've had this experience with
Right.
new
Everybody
baby.
has.
Yeah,
It's like,
it's like
why
it's a
does
full-time job.
everybody hate healthcare?
Yeah, it's like a
right?
full-time job, not only for the people on the administrative end, like you're talking with the hospital and I talked to somebody from the pediatrician. I talked to somebody from the so at the pediatrician that the baby goes to for well child visits. I talked to the pediatrician that saw it was not even I talked to the billing representative for the pediatrician that saw the baby in the hospital. So that's two people.
Okay.
And then I talked to Innova Alexandria billing person at the hospital billing person. So it's three different people. I even ended up talking to one of them for a minute, accidentally thinking they were one of the other billing people. And they were all confused, thinking, why am I telling them this? And it's literally just like, it was a full-time.
Who is this
Yeah,
guy?
so it was like four, if you include me as a full-time person, it's what it felt like.
Oh, wow.
It was four full-time people just to figure out what I was paying. And we could do a whole episode on this, but just to figure out what was done, how much it cost, and who was responsible for paying it. It was four full-time people.
That's not even to get into the why was it done. That's a whole different conversation. But right, yeah, it's a nightmare, right? One of the things when we're talking to employers about why they'd want to consider, or it's kind of part of our sales shtick, but it's also part of our conversation when we bring on an employer. We'll come and present to them at their open enrollment meetings or whenever they want to introduce this approach to primary care. One of the things we'll just say is, why does healthcare basically suck so much, right? It's just awful. It's a horrible experience. And everybody knows they need it, and everybody has people within healthcare they like. Maybe they trust their doctor and they've known them for years or whatever. But the whole process of healthcare through, I call them the big systems, the hospital-owned enterprises, they're so bogged down with rules and regulations and things that the general public just don't understand. It's hard for them to walk in and go, "Oh, I know exactly what I'm getting and what I'm going to pay for it," and da 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 da. It just doesn't happen. It's the only industry in the world where you can't know the price of something before you buy it. Well, as far as I know, there might be others, but none that I'm involved in. I shop where I know the price, right?
All that to say is, this is the big, beautiful bill, HR1, passing,
Right.
allowing HSA funds. It's like a foothold into bringing direct primary care into the kind of the mainstream fold
yes, that's exactly
of
right.
healthcare. So which is great. It's a huge step in the right direction. The other thing I wanted to cover was the on-site employee clinics. Did you see the change that happened here as well?
I briefly read it, but you can certainly refresh my memory about that.
Yeah, so it says under current law does not allow individuals to contribute to an HSA if they utilize certain discounted health services at a health clinic at their work site, because the IRS views such services as a significant medical benefit, therefore incompatible with HSAs. And so the new provision in the bill allows individuals who utilize discounted healthcare services at a health clinic at their work site to contribute to an HSA.
Yeah, hooray. This is remarkable. This, for employers, has been one of the biggest issues with putting something in, such as, we'll still call it direct primary care, but now when you're talking about doing it with employers, there's a million formats now. If you've seen one direct primary care practice, you've seen exactly one direct primary care practice, because we all have done little variations on things. But we do at Reform Medicine, we're doing direct primary care in the membership membership model only for employers. A lot of direct primary care doctors are getting into it working with individuals or families. We've only ever worked with employers in that.
That's a harder business. Like that consumer business, that feels like a harder business, working with individuals.
Yeah, there is you're selling one or two as opposed to 100 or 500.
Yeah, it's almost like software in the sense that if you're selling a consumer software product, you're going to get huge churn. You're going to have to deal with all sorts of pricing, issues, real sensitivities, because consumers only have, their after-tax dollars that they have to spend from their however they earn income, versus a business who can write that off and they can be more consistent and sign contracts and stuff like that.
Right. Yeah. B2B makes way more sense to me. Plus, let's say I'm spitballing, but about 45% of, half of the people in this country, and this is really scary, are on government health care, right? Medicare, Medicaid, um, CHIP, whatever you want to call it. And the other half are on some sort of uh, privately purchased health insurance, or a lot of companies now are going self-insured or self-funded. That's a whole nother podcast. But in any case, ultimately it's the employer who's on the hook for providing health insurance. Again, Obamacare with its mandates that anybody over 50 employees, you got to buy health care, and you got to figure out how to make it affordable for everybody in your organization, which is just I don't know, it's a business killer. I can't imagine how much growth has not occurred because of this. But anyway, um, so that's almost half the country is on employer-sponsored health plans, is the point, right? So there's a 5%, maybe 10% of the country out there who goes to their local agent and buys insurance, or goes to a healthcare.gov marketplace and buys insurance. But almost all the private insurance is through employers. So employers are the ones being killed by rising premiums, and they're trying to figure out ways to make this work. And so if they go self-insured, they kind of have greater ownership in how well they do, and it gives them a stake in the health of their employees that's different than just workplace wellness and so on. It's really takes the employer to a different level of engagement with their people, and there's benefits to that, in the sense of, I think it makes a better employer-employee relationship in many ways. Um, but the point is, that's where the money is, if you want to think of it that way. Go where the money is. But it's also then you have one person you're working with from what does the health plan look like, that covers 500 people as opposed to 500 different people with different health plans, and you got to try to work through what they need as a DPC doctor. And those are, it just makes more sense to me to stay in the employer space. So that's what we've always done. So previously, well, let me talk about this. We talk about it in terms of near-site clinics or on-site clinics. And on-site clinics, kind of obvious in the sense of they usually are a bigger organization that has something like this, at least 1,000, 1,500, 2,000 people or bigger. And they might open a little clinic or contract with a vendor to put a clinic on site within one of their buildings. So it feels like it's at work. But some organizations that size will do it differently, but companies that are smaller, maybe they have 300 or 500 or 600 people, and maybe they're spread out over a region, for example. They'll use what we call a near site clinic, which means they're actually using our building, our clinic space, our people. We function to them like an on-site clinic, so that it feels like this is where they go for healthcare. This is their clinic in a sense, but it's located near site or relatively close by to the workplace, not within the workplace itself. So, on-site, near-site clinics in the past, right? So people would, if you had a health plan.
So is it, in this case, was that a conscious decision on your end because you're aware of this law, or is that just something that was kind of not a huge concern, but it turns out that distinction, near-site versus on-site, that is actually a bigger deal, at least for employees?
Well, for the purposes of our listeners, it's mostly because those terms will come up sometimes. I'll use them: near site clinic, on site clinic. In this case, I think my interpretation of that is basically they're saying on-site clinics, but my interpretation would be, or something that functions as an on-site clinic. So a near-site clinic, I think, would be covered under this as well. The point of it is that you can actually purchase healthcare differently, and it is not direct primary care is not insurance. Direct primary care meaning on-site, near-site clinics for employers anyway. Somebody's just paying you a membership fee, right? That's kind of this arrangement of we buy our primary care differently, because when we do that, it's number one, you can kind of budget for it, right? If we know this is what we're going to pay at this primary care clinic to do this for us, we know that's the number. And we don't have a bunch of fee-for-service variation like January was really a bad month and February wasn't so bad, but it helps with your cash flow as a business to understand how much you're going to pay every month, and you just plan for that.
Yeah, I mean, on the macro and micro, I mean, the economy as a whole, businesses run based on predictability and forecasting, and they make decisions based on that predictability. So, I mean, the benefit is obvious in my mind.
Right. And so it's not that so there's no insurance aspect to it in the sense of we as the primary care doctors, really, there's no risk to us financially. It is, there's only 24 hours in a day. I guess we could be on the phone all day, every day, and so on. But we don't have to kick in a huge bunch of money or something if patients overutilize us. I mean, that's just, you set your membership levels at a level that you understand, you just don't cook that kind of risk into it. It's just not, there's no real risk in it. So, but for a long time, the IRS, good faithful lapdogs of the federal government, they couldn't get past the idea that this was not insurance, and they would see that HSA, high deductible health plan law, and say, well, see, you can't use that as tax advantage money. You can't use that for an HSA membership because that's really buying a level of insurance below your HDHP, and then you haven't done this high deductible thing, and we're giving away tax breaks for nothing. I mean, there's all kinds of weird ways you can kind of interpret that. So it takes the federal government, takes Congress, literally an act of Congress, to come along and go, all right, well, this is how this makes sense. And so the IRS can then kind of change what they're doing and how they're enforcing these rules. But so when you buy your primary care, and the beautiful thing about buying your primary care as a membership is you really, if you're working with a good vendor who's aligned with you, it really is, it's like owning your primary care, right? I own this segment of my care, and I make sure that the people I'm working with are looking out for me, and not looking out for an insurance company that might own them, or a big clinic that might own them, or big private equity that might own them, whoever it is. We want them working for us and getting us the outcomes we want with patient care and cost sensitivity and so forth. So this whole thing, there's so much packed into that product of near-site and on-site clinics. The benefits are just huge. And I mean, we literally have saved employers millions and millions of dollars on healthcare spend because we help them to do it without getting lost in the systems designed to extract money from their health plans, which is most of the big systems.
Yeah, and to that end, the United States Congress is taking, albeit a small step, a very significant step towards recognizing the power of this new model and hopefully making some inroads into the mess that is the American healthcare system. The other thing we've talked about a little bit, but we could just maybe comment on health savings account expansion. We've talked about this in the context of direct primary care, but they've also expanded the list of qualified expenses for your HSA.
Oh, this is fascinating. Yeah. What did they expand to?
They expanded to, you can actually pay for like fitness classes, gym memberships with your HSA. Mm-hmm. You can pay for certain over-the-counter medications with HSA funds. You can pay direct primary care and some other things like that. Do you have any reaction to that?
Yeah. Well, it's interesting. How much can you spend on a gym membership?
It says instructional for physical fitness memberships and instructional physical activity up to $500 a year for an individual or $1,000 a year for a family, with up to 1/12 of such expenses allowed per month.
Okay. What it really gets into is it's the federal government meddling in what words mean, right? So a health savings account you can use for whatever. Before it was for health care. Now a gym membership is health care. Is that what you're saying?
Well,
And
it's a
to
health
me,
savings account. It's health.
right. Oh, right. Yeah. No, I get it. And so the real question is, I mean, I see how they're doing it. I mean, we can all argue about whether it's good or it's bad, but it's this whole idea of how about just give me a tax cut, just cut my taxes and stop, regulating crap like this. Just let me have my money. Let me spend it on whatever. Give me a tax. I don't know, whatever. But they keep the boot on your neck while making you think you're getting some sort of benefit. I mean, it gets back to the whole, why did we have to scratch and claw to get direct primary care covered? I mean, it's paying for health. That's medicine. That's medical care I'm getting. I'm just paying for it differently on a payment plan instead of, where I, as an individual, can have a fixed amount of money every year I'm paying for my primary care rather than have, anybody can plan better that way. They know what the amount is they're paying. They choose to pay that amount to the doctor they choose. That's called the free market, or kind of free. But no, the government couldn't come along with that. For 15 years or more, we've been sitting there with this chokehold around us as individuals saying, you can't buy your health care the way you want. That's not how this is going to work. And now they say, oh, you can use it for a gym membership. Well, okay, well, thank you, Master. I'm glad to have control over $500 more of my hard-earned money, right? I go to work every day. I slave away. It's the fruit of my labor. And you're still telling me, oh, you can go ahead and spend that on a gym membership if you want.
Because it's tax advantaged. I guess that's the pitch.
Yeah, no, that's my whole point. I mean, you're great that, oh, well, okay, just give me the tax break. Why do you have to make that tax advantage? I mean, it's just control, right? It's control. And that's a political statement on my part. It's just control. It's crazy control. I mean, they regulate everything. By the way, I didn't say this earlier, but I thought it. Oh, thank you, federal government. You're going to allow somebody to pay me up to a certain amount for their direct primary care membership. In effect, you're price controlling us in primary care. What if this is a cardiology practice? Would you cap that at $150, or would the cardiologists have paid you off to get you to make that number bigger?
Right. Well, yeah, I mean, realistically, they would have lobbied and educated, I say in quotes, they would have educated the appropriators or whoever, the budget committee that wrote this,
Right.
and they would say, well, these are our economics and this is what this costs. I mean, they're laying it out in the light that works in their interest.
Right. Medicare has traditionally capped primary care at some amount of money that nobody wants to accept as a salary, so they all go into specialties. But it's the same group that comes back and says, well, this is kind of the economics, and this is what primary care. They're price capping us again. They're saying, oh, no more than $150. What about those guys who live in New York City? They live and work in New York. Is that still $150? I mean, what are you going to have to do? Take 2,000 patients? I mean, that's a lot of money. Don't get me wrong. But the point is, the cost of living can vary in lots of places. And frankly, if my patients are willing to pay me $200 a month, why shouldn't they be able to do that with their HSA? Because we're the federal government, we say so. I mean, it's just crazy.
Just this idea of building in these tax credits or these allowable expenses, deductible expenses, it comes from this political theory or this political idea that the government has basically carrots and sticks in policy among their own citizens, so they can incentivize behavior they want to see and punish behavior they don't want to see.
We call that social engineering.
It is social engineering, and the argument would be that, just if I could steelman it, the argument would be from their side, which is we have to collect taxes at some level. We have to do all of these particular government functions, and so why wouldn't we do it to incentivize the things we want to see and punish the things that we don't want to see?
So if you want to see people taking care of themselves, that means you're going to need more primary care doctors. And when you put arbitrary caps on how much people can pay primary care doctors, you artificially limit the number of people who will want to go into primary care because they're having their salaries capped. And the AMA has been doing this to us for 50 years or more. CMS has been doing it, and I'm not. By the way, I'm not pointing fingers at specialty care doctors and saying they're making too much money. They're making what they make, which is fine. But if your complaint is that people don't take care of themselves and they don't have enough there's a primary care doctor shortage, and they'll trot that out and use it for various things. It's entirely true that if you wanted to give, and this is why I got into direct primary care in the first place with Obamacare, was they're not creating more doctors, they're just creating more people buying more insurance. They incentivized a physical, wellness by giving people free exams under their insurance plan, supposedly. But they didn't create any new primary care doctors, and they didn't change anything about how they pay primary care doctors, such that there would become more primary care doctors over time. There would actually become less, because now all of a sudden you have more and more people flooding the system. The medical students and the residents in training and so forth, mostly the med students, would look at the system and go, I don't want to be part of that. Primary care, look at that. Those guys work like dogs and they get paid very little. Relative to their colleagues who also may work like dogs, but they get paid a lot, And so the whole idea of this, the steel man argument you were talking about, I get the idea of incentivizing certain things, but they're missing the big picture, which is, when they talk, and the political left likes to point at other developed countries and say, gee, they spend a lot less money and so on. Well, those countries also have a whole lot higher percentage of primary care doctors to specialty care. And they have things in place that incentivize that.
And that is kind of the follow-on argument of people who are in favor of single-payer systems, which is you see all the issues that arise when you take this paternalistic approach, just kind of this nudging approach. You want to incentivize this, you want to tax credit that, and you create all of these distortions in the market that aren't fully, you can't predict. I mean, it's such a complex system. That's the beauty of markets, is markets take care of themselves in a lot of ways. But if you interject some sort of externality or external pressure on it, it's impossible to know all of the ramifications and all of the problems that will arise as a result of people acting in response to these incentives that you so brilliantly put in place. And so the argument is on the single payer end, which is, well, if we just take total control of the system, then we can address with policy or with, through a bureaucracy, we can just address everything that comes up at the government, at the policy level, and just cram down on it or fix it in quotes, as it arises, rather than living with the inconveniences and the misaligned incentives and all of the complications that arise when you try to get involved in the marketplace. And again, I'm not advocating for single payer at all, but that's just the argument that comes up is you start trending towards this. And that's been the argument from the Obamacare era, right? I mean, this public option we need to have a public option. We need to move to single payer, blah, 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 because this whole Obamacare intervention in the market just has clearly not worked.
It hasn't done what they wanted it to do. We still have 30 or 40 million uninsured people in this country. That was the promise. Oh, we're going to insure everybody. Well, we still have the same number of uninsured in this country. But my response would be, well, let's look at the things the government has sole responsibility for. The federal government, nobody else can do it. In fact, under the Biden era, they were trying to litigate against people trying to do it. Let's talk about managing immigration and the borders. They have sole responsibility for that, right? But every political cycle, somebody comes out with the demagoguing the whole idea, we need comprehensive immigration reform. Okay, well, that nobody else can do that. That's a federal government thing, right?
Yeah.
One of the things that Elon Musk and Doge has shown us is there isn't any department in the federal government that isn't full of bloat and fat and waste and fraud and abuse. The other thing that none of us can do anything about is the military, right? So military, we like to say it's great, blah, 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 blah. But if it's mismanaged, you get low recruiting numbers, you get all this kind of bloat. It takes a long time to produce anything that we need, it takes a long time to produce, defense contracting, all that stuff, because the federal government owns the whole thing, right? And nobody else can do anything about it. And that's what you get in healthcare. It would just become one big, fat, bloated bureaucracy. And, it would get demagogued, and every 2 years it would get trotted out there. And uh, well, I guess when I left the big system 15 years ago, when I made the decision, it was in light of the idea that this Obamacare thing is either going to die under its own weight, because I think it's unconstitutional. John Roberts did too. He just didn't say it that way, and therefore it didn't die. But the point is, it was either going to die of its own weight, and we'd be back where we were, which there was a market for that. Just to have cash basis, just access. You could just charge what you wanted, and people would pay you because they just need to be able to get in to see their doctor. Or the other thing would be, it doesn't die, and it just creates a situation where it gets worse and worse and more expensive and more bloated, that people ultimately say, we just want a single payer system. And if we could get enough people to vote that way, then you'd have a single payer system. Well, so the single payer system, this still being the United States of America, I presume you have one payer, only one third party payer, and that's the federal government, but they couldn't make the private practice of medicine illegal, right? You could still do a cash practice. And so you would have this entire cash economy in healthcare would develop, which it has. People don't talk about it much, but employers are doing it more and more and more. So you can get a knee replacement for $25,000 instead of $60,000 because you're paying for it differently. So it either dies under its own weight or it becomes a single payer system. Either way, you have a cash economy that's going to occur. A single payer system in many ways would just, we're already half the country's on the single payer system. The federal government, Medicaid is 90%.
It's worth pointing out in other countries where there is a single payer system, there exists a cash economy, a secondary market for people who can pay for it. That exists. If it's not made illegal by those countries, it exists.
Right. And the people with means will always buy up. Everybody who can is going to buy up. And so but it's a better way to practice medicine when you're doing what the patient wants you to do, needs you to do, than what some government hack is telling you have to do in order to meet some quality metrics, so they'll keep reimbursing you. So either way, I was like, I got to get out of the system, because that anything the federal government touches just goes to heck.
That's a good place to pivot to just the last question, or the last topic here, which is, what do you think this means for the immediate future of the direct primary care space, for HSAs, for what you do? What would you tell a doctor, or a primary care doctor like yourself, or a small business owner, or a health savvy patient? What would you tell them is maybe coming down the road as a result of this, or what to do, what advice you'd have?
Yeah, it's interesting that for a long time, the regulatory weight, the administrative weight of Medicare and Medicaid, and the shortage of primary care doctors, you put those two together, and what you get, primary care practices, family practices like mine, would get this glut of people who, because there's a doctor shortage, you would have long wait times. Your patients would just be 6 weeks or 8 weeks before they could see you. And if you had some arbitrary rule in there, like, I don't do annual physicals except twice a day, and then they'd call and they want their annual physical, and we'll do that in 6 months. And it was really dissatisfying for patients. Anyway, the administrative weight of that, of trying to get money, trying to get paid this little amount of money from Medicare that you get paid, or Medicaid, and all these patients who want to see you, there's huge demand, very little reimbursement, and increasingly fractionated or vertically integrated healthcare systems. So hospital systems in Eau Claire, there was 2 or 3, and so these systems would go around buying up small primary care practices, because primary care doctors were fed up. They just couldn't do it. They couldn't pay their staff and bill Medicare and see all these patients, and they were losing money. It wasn't paying to stay in private practice. So all these big systems gobbled up all these primary care providers in order to generate referrals for themselves. I think what I would tell people is, you're going to see an exodus from the big systems of primary care doctors who will finally have somebody acknowledge the worth of good primary care that actually makes people healthier and prevents disease, and keeps people out of the expensive ERs and urgent cares, and doesn't send them for MRIs that they don't need, and all these things, because the primary cares exist within the big systems precisely to generate those referrals, particularly if they don't hire enough of them, and then they don't pay you well enough, and then so you can't get enough of them. So you're always underfunded, understaffed. It's easier to just take somebody in and go, oh, yeah, I don't have time for that. Let's send you over here for an MRI and we'll get some lab work and I'll see you back. And, it spins off all this work and money. And all the big money in healthcare is not being paid to primary care doctors, though it should be more of it. That's a little self-serving to say. But if you want more primary care, you gotta pay them better so it competes in the medical school marketplace. But the point is, I think what I would tell people is watch for this coming soon to a theater near you is direct primary care will be popping up in lots of places where you've never seen it before. And the concept of it is going to change as soon as people start to understand that, gee, you can buy your primary care differently. Wow, okay, I'll do that. And don't get me wrong, by the way, $150 a month for a direct primary care membership isn't anything to sneeze at, but that's the difference between, maybe a small city like Eau Claire, Wisconsin. If you go over to Minneapolis, the Twin Cities, I mean, the difference, $150 is kind of a standard monthly amount over there for some direct primary cares. I don't know what it would be in New York or a big city where your cost of living is so much higher. That number is something that I think somebody may have to tinker with, just the idea that it's literally a price cap. So, and Medicare price caps, and that's its problem, is you won't get more primary care doctors as long as you're capping them at relatively low amounts of money because they can't make a living doing it. So anyway, there you go. We want to short the primary care within the big systems because I think those are going to really shrink up. The market for that's going to go down.
He is a medical doctor, but this is not financial advice. He's not a financial advisor for educational entertainment purpose only.
And I don't know how you sell short on a nonprofit health system's primary care anyway. But that's the thing I would look for is doctors will leave those systems like I did, and the ones coming out of residency will never join them on an increasing basis. So I think it's all good. I think it's good for the country. I think it's good for everybody to have primary care that actually works for the patient and not the system.
There you have it. Big system primary care down, independent direct primary care up. Step in the right direction.
Thanks for listening to The Treatment Plan. If you enjoyed the conversation, subscribe on YouTube, follow on Spotify or Apple Podcasts, and turn on notifications so you never miss an episode. And if someone comes to mind who'd like this show, tell them about it or send it their way using the share button.